Two Scottish gentlemen meet on a train. One of them says, "What's that package up there on the baggage rack?" "Oh, that's a MacGuffin," replies the second man. The first one asks, "What's a MacGuffin?" The other man replies, "It's an apparatus for trapping lions in the Scottish Highlands." "But there are no lions in the Scottish Highlands," says the first man. The second one answers, "Well, then that's no MacGuffin." Now, Alfred Hitchcock, who is certainly unparalleled master of the mystery suspense film, cited this anecdote when he was asked about the origin of the term MacGuffin, which is the label that he used for any plot device or gimmick that could serve as a catalyst for intrapsychic and interpersonal conflict among the characters in his films. A typical MacGuffin might be plans for a weapon that were hidden by the inventor before his untimely death. The plot then develops around the adventures of the various characters whose lives are affected by the efforts of rival intelligence agencies to locate and secure the plans for their respective governments. While the audience generally was deceived into thinking otherwise, Hitchcock knew that the MacGuffin was in reality of little importance to the film. The real meat of the story lay in the counterpoint of emotions and behaviors evoked by the MacGuffin. Various characters would come to grips with fear, rage, guilt, compassion, love, lust, envy, jealousy, and grief. They might demonstrate surprising bravery, cowardice, greed, altruism, loyalty, or betrayal. In the final analysis, as Hitchcock and his Scottish anecdote both suggest, the MacGuffin sometimes turned out to be nothing at all. Now, one might wonder what memories possibly could have in common with Hitchcock's MacGuffins. I would submit that the similarity at times may be more striking than we would like to believe. I draw on this analogy to give you an idea of the complexity of autobiographical memories as viewed from a psychodynamic perspective. And really, I'm here today as a proponent of good psychotherapy. Much controversy and debate has arisen lately over the causal role of childhood physical and sexual abuse in adult psychopathology, including, to name only a few, anxiety and phobic disorders, depression and suicidality, sexual inhibition and promiscuity, eating disorders, what's called codependency, multiple personalities, substance abuse, and severe character disorders. Some authorities would have us now refer to these as forms of delayed post-traumatic stress disorder, similar to the model developed for the understanding of the stress response syndromes seen so frequently in combat veterans of various wars, including the Vietnam War. However, the war neuroses, as they were once called, usually involve documented, easily verifiable traumas. Memories of early childhood traumas initially recovered by adults during the course of psychotherapy, on the other hand, present a much more complicated challenge to clinicians and researchers. A particular type of psychotherapy based on this childhood trauma model has attracted much attention recently because of its controversial theory and technique, and has generated this conference, as well as many others. This particular type of psychotherapy has been labeled recovered memory therapy, usually by its critics, because its chief focus is on the belief in and active pursuit by the therapists of suspected hidden memories of childhood physical and or sexual abuse in their patients or clients, regardless of their presenting complaints. The failure to recall the abuse is thought by these therapists to be the primary cause of their patients' symptoms. RMT is based on the premise that detailed memories of childhood trauma are stored in the brain in a pristine form and can be retrieved decades later as if replaying a videotape, often through the use of special techniques. For example, hypnotic suggestion, sodium amytal interviews, or sometimes relaxation techniques with suggestive guided imagery. By searching out, uncovering, and, quote, reliving, unquote, usually unverified and often unverifiable alleged past traumas under the guidance of specially trained trauma therapists, patients reportedly are able to, quote, metabolize, unquote, the trauma memories and experience permanent symptom relief. There's a problem with all of this, however. As you have heard over and over again today, memory storage and retrieval just doesn't work in such a neat, linear fashion, and neither does good psychotherapy. In trying to come up with kind of an analogy for recovered memory therapy, I've come up with various ones. MIC therapy is one of the terms that I used for it. It's sort of a fast food type of therapy, but I think it's something that's kind of analogous to it. Turned up in a cartoon that I found. I'll see if this slide comes out right here. This is, if I can get it in focus, drive-through brain surgery. RMT, in my observation, often turns out to be about as effective as drive-through brain surgery, sometimes leaving serious psychological scars on patients and their families. Additionally, I believe that its controversial nature threatens the hard-earned credibility of traditional psychodynamic psychotherapists everywhere. An impressive amount of experimental and clinical data accumulated over the past century demonstrate that memories represent reconstructions or approximations of past experiences, rather than wholly accurate reproductions of past events. These reconstructions are heavily influenced by conscious and unconscious fantasies, beliefs, moods, attitudes, wishes, and worries. According to mainstream psychoanalytic theory, these influencing factors in turn are products of an ongoing series of unconscious conflicts and compromises. A host of mental mechanisms continuously strive to minimize anxiety stemming from ambivalently viewed sexual and aggressive drives and impulses in the context of elaborate fantasies and beliefs about the self in relation to others. The goal is homeostasis, to maintain a sense of order, security, and well-being by adapting as best we can to a rather unpredictable environment. The price we pay for this self-deception is to journey through life with a very subjective sense of reality. Blending internally derived fantasies with subjectively colored perceptions of external reality, we create a life narrative, as Dr. Spence pointed out so well, that under scrutiny may or may not closely approximate historical truth. Now, there's an analyst named Jacob Arlo who came up with this sort of metaphor or analogy for subjective experience, and it involves having two projectors. Interesting that we have a rear screen projector operating right now that's allowing you to view this slide. Well, if you look closely, you can see a projector on either side of that white screen in the middle. And what that white screen represents is subjective experience. One of the projectors is projecting onto it what might be our imperfect perceptions of objective external reality. The other projector is projecting onto that same screen from the other side our unconscious psychic reality, which consists of all the things that I talked about, fantasies and wishes and worries and everything that tends to be starting in childhood and continues to be the residual of childhood fantasies as we grow up. And these things color our way of perceiving the outside world. In fact, subjective experience then turns out to be no reality at all, because it's really a blend of the two. Now, what about psychoanalysis? This is my favorite psychoanalysis cartoon. And if anybody's listening to this on audio tape, there's a scene of a guy drowning trying to get Lassie to save him. So he says, "Lassie, get help." And then the next scene shows Lassie on an analytic couch. So. Psychoanalysts and analytically oriented therapists lately have become the target of some negative journalism as the result of misconceptions about how analysts deal with memories of childhood experiences. Critics of the faddish and potentially harmful RMT often cite Freud's earliest and least sophisticated theories of psychoneurosis as the cause of the present epidemic of what some claim to be therapist-generated false memories of childhood physical and sexual abuse. They've laid the problem squarely at the feet of psychoanalysts. Now, it's true that the younger Freud, relying heavily on hypnosis and suggestion early in his practice, initially pointed the finger at repressed memories of childhood sexual abuse as the first link in a causal chain of events resulting in neurotic symptoms. However, accumulating clinical data soon led him to the discovery in adults in adults, that's who he was studying, of a partially conscious, partially unconscious, as I was just talking about, complex internal world of residual childhood fantasies with sexual and aggressive themes. This provided him a broader theoretical understanding of psychopathology. Such fantasies did not require the presence of actual physical or sexual abuse as precursors to intrapsychic conflict, although Freud never entirely ruled out actual abuse as a potential risk factor. Neurotic symptoms, though, now were viewed as products of unconscious conflicts over the expression of sexual and aggressive fantasies, wishes, and urges. The historical validity of childhood memories and experiences became less important to Freud as his attention turned toward the manner in which feelings, drives, fantasies, and mental defenses, originally experienced as reactions to significant persons in childhood, were later reactivated in treatment, displaced onto the analyst. He labeled this process transference. Analyzing transference became the primary key to the identification and resolution of unconscious conflicts and the symptoms caused by them. It is this process, and not the uncovering and expunging of hidden childhood trauma memories, that continues to be the focus of modern psychoanalysis. Most analysts today are less interested in the specific content of a patient's memories than in analyzing unconscious conflicts, defenses, and compromises that affect one's ability to work, play, and love. Analysts and most analytically oriented therapists are careful to maintain neutrality about the historical validity of childhood memories that emerge during treatment. They recognize that many, and perhaps all, memories, like symptoms, are compromise formations, subject to the vagaries of unconscious defense mechanisms, operating to keep intrapsychic conflicts out of conscious awareness. Now, I want to make a point here about repression, that repression's getting a really bad rap, too. If there weren't a repressive barrier that allowed there to be this active, unconscious mental life, I don't think there could be confabulated memories. There couldn't be pseudo-memories. Because if you think about it, the only way that patients and their therapists are able to get caught up in believing what comes forward has to do with the fact that these memories seem to come forward effortlessly. The patient is not aware of consciously constructing the scenario. What happens particularly under hypnosis, similar to as in dreams, the patient is just passively receiving this as if it's being transmitted to them from somewhere. And it has to come from somewhere, and they're not consciously aware of where it's coming from. And so it seems to them that it's coming from some memory bank somewhere. But in fact, it might be coming from efforts of unconscious defense mechanisms to come up with some type of material that will allow for a compromise. And a clinical example I'm going to give you in just a minute will show you how that can happen. Indeed, rather than always leading to insight, some memories may operate as a resistance to insight, drawing the patient's and sometimes often the therapist's attention as well away from conflicts that are the true source of the symptoms. Memories that eventually prove to be entirely false or confabulated might be considered the purest form of such elaborate diversionary tactics. In this manner, a particular memory may act very much like Hitchcock's MacGuffin. Its material importance may turn out to be no greater than the purpose it serves as a vehicle for the acting out in the transference of unconscious fantasies, wishes, and fears. A case example helps to illustrate this point. Ms. R. sought psychotherapy for sexual inhibition with her husband. She related a history of growing up as a daddy's girl, always feeling closer to her father than to her mother. He was attentive and affectionate until Ms. R. reached puberty and began to show a romantic interest in boys her own age. Her father then quite abruptly withdrew his affection, both physically and emotionally. Ms. R., as an adult, recently had read a self-help book that identified childhood sexual abuse as a common cause of sexual inhibition. Recalling how physically affectionate her father had once been, she began to wonder if she could have repressed or dissociated memories of sexual abuse by him. A friend taught her how to use self-hypnosis to, quote, get in touch with hidden memories, unquote. In her therapy sessions, Ms. R. began to spontaneously regress into trance-like states during which she vividly reenacted graphic childhood, quote, memories, unquote, of frank sexual encounters with her father. Now, rather than being drawn into a speculative debate about the factual validity of these new, quote, memories, unquote, The therapist instead chose to focus on the meaning of these regressive enactments as they were now occurring within the context of the transference. He carefully explored the patient's fantasies about the therapist. Gradually, the patient realized that she had transferred onto the therapist not only her love and affection for her father, but also her fear of frightening him off with her emerging sexuality and sexual fantasies. The memories, quote unquote, of sexual encounters with her father, which came to her in a childlike regressed trance state in therapy, provided her an acceptable unconscious compromise. As a passive, victimized little girl, she could bring sexually provocative material into the therapy sessions with minimal risk of physical or emotional abandonment by her therapist, who had come to represent a substitute father figure. Eventually, Ms. Czar revealed a fantasy of being physically held and protected by the therapist if she could only relive enough childhood trauma experiences in his presence. From reading her self-help book, she had concluded that therapists expect and want their patients to react that way. Through such enactments, Ms. Czar had hoped to recreate the sorely missed real-life experiences of being lovingly held by her father as a child. Still later, she disclosed having felt sexually stimulated as a child when held close by her father, and she acknowledged feeling guilty and anxious about this. Likewise, she felt guilty and anxious about her adult sexual fantasies toward her therapist that had emerged as part of this transference reaction. Ultimately, Ms. R. understood how she had displaced similar wishes and fears onto her husband. She unconsciously feared that overtly expressing her sexuality would frighten him away, as she perceived it had done with her father. As her insight increased, her childlike regressions and accompanying abuse reenactments no longer served a useful purpose. They dropped out of the picture, and eventually Ms. R. concluded on her own that these, quote, memories, unquote, had been fantasies created in the service of blocking from consciousness unresolved conflicts about expressing sexual wishes and urges. Now, while this explanation oversimplifies the complex dynamics of conflict and compromise within Ms. R.'s mind, it shows how in some cases confabulated memories, like MacGuffins, may serve merely as a plot device in the drama of psychotherapy. A particular memory in itself may have little intrinsic value when taken literally, but it can serve as a vehicle for understanding the thoughts, feelings, wishes, impulses, behaviors, and attitudes towards self and others that emerge in the transference during therapy. Hitchcock was often frustrated by scriptwriters who had not previously worked on his projects. Invariably, the writers would become over-fascinated and even obsessed with the MacGuffin, despite being told repeatedly by Hitchcock that it was not important. Many of today's psychoanalysts, no doubt, are similarly frustrated with high-profile, quote, recovered memory therapists, unquote, who are taking dynamic psychiatry into a potentially disastrous evolutionary U-turn by once again targeting repressed memories of childhood physical and sexual abuse as the primary cause of neuroses and character disorders. RMT proponents appear to be paying scant attention to 100 years of clinical and experimental research that demonstrates the complexity rather than the simplicity of the human mind. The reductionistic linear hypothesis that repressed trauma memories alone cause psychiatric syndromes was abandoned by Freud not long after he proposed it. Now, nearly a century later, it has been revived, dusted off, and put back into service under the guise of a new paradigm in psychiatry. Those who believe that it will stand up to careful scrutiny better than it did the first time around would do well to consider the wise observation of the philosopher Hegel, who said, "What history teaches us is that men have never learned anything from it." Thank you.